Rapamycin is probably one of the most promising longevity medications we have right now, but a recent study is raising potential concerns about its effectiveness. It might suggest that rapamycin blunts the body's ability to respond to exercise. So the question is there something wrong with rapamycin, or was there something wrong with the way the data is interpreted or the way the study was done? Today, I'm going to walk you through the study, and I'm going to give you my thoughts on the study and why I think rapamycin is still a very promising molecule. So here's a study. It's in preprint, so it hasn't yet been officially released, but the preprint usually ends up to be what ends up in the final, or a variation of the preprint usually ends up in the final publication. So let's walk through this. This is about a 15-page article. I'll put the link in the notes, but you can find it as well if you Google it. It's called Exercise in Weekly Sirolimus in Older Adults, Placebo-Controlled Trial. So the lead author here is Dr. Brad Stanfield. He's a physician in New Zealand, very enthusiastic on longevity. He has his own YouTube channel as well. And he self-funded as well as fundraised for this trial. So very admirable. And actually, when I first heard about the trial, I was very skeptical. I'm like, of all the things you want to test rapamycin. And then as I started learning more about his rationale, I'm like, okay, well, maybe he's got something there. And then he actually launched the trial, and it sounded like it was on its way, and there was supposed to be some promising studies. But then if you kind of do a news search, you'll see that this will probably hit the headlines more when it comes out more officially. But here's a headline: one of the most promising anti-aging drugs just failed human test. So you'll probably see more of this once the study actually comes out. So you can read through this. It talks a little bit more about why, where that headline is coming from. But I wanted to walk you through it. And then the other thing I want to point it out, so the second author on the paper is Dr. Matt Kaberlin. He's a very well-known researcher, became famous for rapamycin, his involvement with the dog aging trial at the University of Washington. And then, he and Dr. Stanfield put together this recent YouTube video, and they're kind of discussing. So feel free to check this out as well. I'm going to give you my take on it. So a little bit of background on myself. I'm a longevity functional medicine physician. I've been enthusiastic about longevity for over 20 years. When I learned about rapamycin, I fell in love with it as a molecule. There's a lot to say about rapamycin, but long story short, it's a natural occurring molecule that was isolated from a bacteria from Easter Island. That's why it's called rapamycin. Rapa Nui is the native name of the Easter Island. And so when they found this molecule, they called it rapamycin. Initially, it was being investigated as an antifungal, and it does have antifungal properties, hence the mycin part of it. The mycin usually means like an antimicrobial. Think azithromycin or erythromycin, for example. So given the name rapamycin. As a drug, if you go to the drugstore and you ask for it, it's actually goes by the name sirolimus. Don't ask me why. That's just the way the drug company decided to name it. But from a research perspective, it's called rapamycin. Originally used, its original FDA use was approved as a immune suppressant for people who underwent kidney transplant and other transplants. Like I said, it was originally thought to have an antifungal property. It does have antifungal property, but when they started giving it to animals, to mice and rats, they noticed that it suppressed its immune system, because a lot of times new molecules are tested on animals, and they look to see what the animals do, and then they say, oh, this is an antifungal, but it also suppresses the immune system, and so that's kind of how it led down the path of being an immune suppressant, a transplant drug. It also has some other uses. It seems to have some anti-tumor activity and whatnot. And then it was discovered that smaller doses, actually, organisms live longer: yeast, worms, mice, and monkeys, at least certain types of monkeys. And we think maybe eventually humans. That's why it's very promising, because every organism's been tested on so far, it seems to help them live longer. And there's various different mechanisms, that behind it. There's mTOR and mTORC and all these other things that you can go into. But the trick seems to be finding the right dose. And that's kind of where there's been a little bit of challenge. All right, so now that I've given you a little Rapamycin 101, brief intro, let's go ahead and jump into the study. So it is a 13-week study. It was randomized control. And I'm going to kind of pause, and 5 are excluded, 40 are randomized, 20 and 22 placebo. And then they There was a few people who discontinued, and then they ran an analysis on about 20 and 20 total. Well, 15 and 16, I should say. So they had a bunch of different measurements. You can kind of read through this. But the kind of the disappointing part that you'll see, or the reason why this is thought to be kind of a failure for rapamycin, was because they looked at various different physical measurements. So take a step back a little bit. Let me pause for a second so I can show you the study design. Now, well, Dr. Stanfield and his group is that they actually published the protocol. So you can see here, here's a study protocol. That was the website. This is a PDF version of it. And so they published this back in 2024, before they got started. So you can read through the protocol to see exactly what they wanted to do with it. Sometimes, you do deviate a little bit from protocols, having done several clinical trials, and people who have done clinical trials, it can be really hard to follow the protocols. But the nice thing about the protocols, it tells exactly what they're going to do, week 1, week 2, all the way through week 13, exactly what they're planning on measuring, exactly what they're looking for outcomes, inclusion criteria, exclusion. So they're looking for things like what's called the primary endpoint and the secondary. So the primary outcome, let's see here, where is it listed? Give me just one moment. Chair stand test, 30 CST, and then the measurement to look to see how somebody does when they go from sitting to standing. And then looked at secondary measurements such as grip strength, 6-minute walk test, epigenetic clocks. They had to throw that in there because people were going to ask about it. Inflammatory markers and other things. So you can kind of read through this, and you can see like at what point, at what visit. There was 4 visits throughout the test or throughout the trial. At what visit they did what. So this is a very detailed protocol. So I highly commend the team for putting this together. So the question is, where did it fall apart? What happened? All right, so I'm switching between these because the website format's one way, the PDF format's another. So I'm trying to give it to you in the best format possible. So here we have the kind of the main outcomes, and here we have baseline and at 13 weeks. You have the placebo in black, and this is the chair stand test. So you can see that the placebo actually did better. So at baseline, the two groups were, as you would expect, pretty much right on top of each other. But then as the 13 weeks went by, they diverged, where the placebo actually seemed to do better. They both had gains. You can see they both gained, but the placebo actually gained more. And you can also look at individual trajectories. You can look at distributions, whatnot. So this here that tells us that it failed to meet its outcome, its primary outcome. And not only that, but the placebo group appears to have, at least through the study, appears to have done better. And so then you're like, Dr. Z, why are you still optimistic about rapamycin? Let me walk you through some more of the data and begin to understand why. All right, so I had to modify the PDF file slightly. I had to turn the vertical page horizontal here so you can actually see the full table 6. Rapamycin to hundreds of people back when I was involved with a longevity company, Ageless RX. And I was able to look at many, many trends across time, not just across a few weeks like this study, but across a couple of years. And what I observed was you'd almost always see, not always, but almost always see a bump in metabolic markers such as LDL, triglycerides, A1C as well would go up. Those were kind of the 3 markers that I saw consistently change in people who were starting rapamycin. So that made me think that there was something metabolically going on. And so now I'm going to kind of show you that that's actually what we saw here as well in this trial. So draw your attention to, let's see, LDL. Here we go, LDL cholesterol. So baseline 2.84. Now this is SI units. So it's hard to convert, but it's the trends that matter, not the raw numbers. I used to work in Canada for a while and it drove me crazy. These numbers drove me crazy. So if they drive you crazy, I don't blame you. So it started at 2.84 baseline. Placebo went down to 2.55. So that's about a 0.3 reduction. The rapamycin group went up by 0.1. So now there's a difference, where they started out the group the same, the placebo group went down and rapamycin went up. That to me tells me there's something going on with the metabolism. There's some kind of metabolic restructuring. Likewise with triglycerides, the baseline was 1.34. Placebo went um, let's see, hold on. Just a second. All right, sorry, I misspoke about the LDL. So the LDL went from 2.84 to 2.96, and then for the placebo went from 2.55 to 2.4. So up with the rapamycin, down with the placebo. For triglycerides, same thing. Down with the placebo, went down by a bit, and then up with rapamycin, up by quite a bit, actually. That's a fairly significant jump, I think 15 or 20%, if my mental math is treating me correctly. So, that's what you would expect for somebody who's like undergoing metabolic restructuring, so to speak, for lack of a better term. And you'll see this very often, people who are on a weight loss program, who are fasting, who are, undergoing changes. Their LDL is going to go up and the triglycerides are going to go up. And it's almost always temporary. And that's why I think the biggest problem with this study was not what they were measuring, wasn't the dosing. By the way, the dose was 6 milligrams once a week for 13 weeks. It was the timing, the amount of time that the patients were on this. The theory of rapamycin is that it affects various different parts of metabolism, including a system called autophagy. Autophagy is where the body, in order to recycle, so you have proteins that misfolded proteins, you have cellular debris, you have mitochondria that are not working properly. So in order for the body to work properly, it needs to digest these and recycle them, breaks them down, recycles them, makes new mitochondria, new protein, new cells, things like that. So during that period, you're going to see a messy metabolism. Imagine, I don't know, you walk into a house in the middle of its reconstruction. Of course, it's going to look messy. Maybe the roof is not as strong as it should be. Definitely not going to function. The sink might be turned off. So that's, I think, what we're seeing here. I think we're seeing reconstruction in progress, 13 weeks in elderly patients, just not enough time. I would like to see them do a much longer trial. Now, to Dr. Stanfield's credit, this is a very expensive trial. He said a little over $700,000. I think he contributed. He took a mortgage on his house, from what I've heard, in order to pay for some of that. Crowdfunded the rest, and he was able to raise some of the rest. So it's not an easy thing to run a trial, but this is the importance of having long-term trial. Now, in contrast, the rapamycin trial that I was one of the lead authors on was called the Pearl trial. The Pearl trial was a 12-month trial. But the Pearl trial was that we didn't dose it properly because we didn't know that the compounded capsules were not properly absorbed. So we ended up underdosing. But even then, we found that women, because I think women are more sensitive to the medication and need lower doses, women had an increase in their lean muscle. Now, if we measured it at baseline, 12 months and 6 months, I suspect if we would have measured things at 12 weeks like they did, or 13 weeks, we probably would have also seen a gap between our placebo group and our rapamycin group. So this study was done for a much longer period of time. You'd see not only the rapamycin group catch up, but start exceeding the placebo group. So I think that's where it went wrong. So bottom line, this study doesn't show that rapamycin is bad or disappointing or doesn't work. It shows that you have to understand the basic biology behind rapamycin, the concept of autophagy, and you have to give it time to work. I mean, I'm not sure, why it was decided at 12 weeks. Maybe that's all they could afford. But the very least they could have done was, okay, maybe set aside extra money, or maybe do fewer measurements, and maybe, continue out. They could have stopped the treatment at 12 weeks, but they could have continued out the measurements until, let's say, 6 months. And I think if we would have 6 months, maybe 12 months, we would have seen a catch up, not only a catch up, but maybe the rapamycin group exceeding, because it does take time. So I think, the good news is there are a lot of other groups, actively looking at rapamycin for all sorts of things, for chronic fatigue syndrome, for fertility, and then the HealthSpan X Prize, I think, is going to be very interesting. So stay tuned. There's a lot more data to come. Don't give up on rapamycin yet. I think it's a very promising molecule. And if you want to learn more, you can follow my channel. You can follow me on social media, and you can visit optionalaging.com. We'll see you there.